Good afternoon and welcome everyone to our information and support session. My name is Kathleen Helgeson and I'm the coordinator of the Patient and Family Resource Center. I'm joined today by Dr. Davinder Jassal, Section Head of Cardiology at the University of Manitoba, who will be sharing his expertise and leading our discussion about the relationship between cancer and heart health. We are very pleased to offer this webinar with the generous funding support of the Cancer Care Manitoba Foundation. I'd also like to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe Cree, and Dene people, as well as the homeland of the Métis Nation. It's important for us to foster inclusion and reconciliation and encourage others to do the same. You'll notice as an attendee, your microphone and your video are turned off. If you have a question for Dr. Jassal at any time during the interview, just click on the Q&A icon on your screen and you can type your question. You can also choose to send that question anonymously by clicking the blue arrow or checking the box send anonymously before you click on the blue arrow to send. My coworker Ellie is also here off screen and she will be helping manage your questions as they come in. If you have a technical concern, you can also ask Ellie through the Q&A and she will answer your question privately and try to assist you. It's my pleasure to now introduce our guest. Dr. Davinder Jassal was born in Thompson, Manitoba and graduated from the University of Manitoba with an MD in 1998. He completed a clinical and research fellowship at Harvard Medical School in Boston and joined the University of Manitoba in 2006 as an academic clinician scientist, where half of his time is devoted to patient care in the coronary care unit and cardiac imaging, and the other half is devoted to translational research. Among his many accomplishments, Dr. Jassal has been the recipient of numerous research awards and has over 350 peer-reviewed publications. Welcome, Dr. Jassal.
Thank you very much for the invite, and I'm glad everyone had a great summer, and welcome to September 29th, 2022.
Thank you very much, and thank you for making time to join us today. We're really looking forward to having this discussion. Can you tell us a little bit about the work that you do at the St. Boniface Hospital?
Sure, happy to. So at St. Boniface Hospital, as many of you may know, we're sort of the capital for heart health for the province. And so in total, we have about 29 heart specialists that work at St. Boniface. I'm the chief of cardiology, so I'm the boss. And with all of our family members in terms of the 29 cardiologists, anytime a patient has any symptoms that may be related to their heart, meaning that they have pains in their chest, they may have some shortness of breath or some fluttering in their heart, what often happens is patients such as yourselves would go see your family physician, your GP, and then you would get referred to one of us cardiologists to figure out what the symptoms are due to and whether it's related to your heart. And then I guess in particular where we are today, Kathleen, about what I specifically do. So amongst the 29 cardiologists, we have expertise in different fields. So if you have the doctors who are helping with your heart attacks, I call them the plumbers, and they're doing the balloon and stents of opening up blocked pipes. I have my colleagues who are the electricians. So if you tend to pass out and you need a pacemaker, they'll put a pacemaker in for you. I have my mechanics, and so those are my heart failure transplant doctors. And if your heart is really weak, they would be in charge of the heart failure aspect of giving you a new heart. And then there's individuals like me who are called the photographers. So I'm a photographer, meaning that I use imaging of the heart, where we put a little bit of gel on your heart to see how your heart is pumping. And what I tend to do is I focus on this brand called cardio oncology, cardio meaning heart, oncology meaning cancer. And specifically, if there's any cancer patients in Manitoba who are being seen by their family physician, or more importantly, the Cancer Care Manitoba docs at both St. B and HSC, and if there's something happens to your heart from the cancer itself or treatment, I'm be there to help you out, because that's what I do. And I've been doing this since 2006.
So is that when the cardio oncology clinic was established in 2006?
Yeah, correct. So after I did my medical school training here back in the day in the 90s, wow, 25 years ago, I went off to Halifax to become a cardiologist. And then I went to this small eastern town called Boston, a university that you may have called Harvard. And when I was there, what I learned was that there were patients who were being treated for their cancer with various forms, whether it's chemotherapy, radiation, surgery. And when the cancer was getting cured, that was wonderful for the patient. But then we saw patients coming in with heart issues, either related to the cancer or more importantly from the treatment. And so I dedicated those 2 years from 2004 to 2006 to learn everything about cardio oncology, cardio heart oncology cancer. It was a brand new field of medicine. And I said, let's bring it back to Winnipeg, let's bring it to Manitoba and help establish this clinic so that we can help our patient population, our province. And when you look, Kathleen, across the country, there may be about 10 to 12 cardio oncology clinics in the entire country. We're a very small country, although we're geographically vast. There are only about 10 to 12 cardio oncology clinics, and each province has a specialist, a heart doctor, and cancer doctors who work together to help treat patients and manage any concerns we can have.
So can a patient, or how does a patient get referred to you if they're a cancer patient and they're concerned about heart disease? Are they referred? Can they self-refer, or do they have to be referred by their own oncologist?
Yeah, so it's a great question. So I, amongst all the roles that I have, I do clinics on Tuesday afternoons, and that's my cardio oncology clinic here at St. Boniface. And in the patients that I see, which are often around 10 to 15 on a Tuesday afternoon, majority of the cardio oncology patients, whether they're new patients or follow-ups, will be coming from Cancer Care Manitoba physicians or our family physician outreach docs out in rural Manitoba who are managing our patients. The largest proportion of patients that I'll see, Kathleen, are women with breast cancer. That's the largest population. Others would be patients with lymphoma, sarcoma, and others. But the reason I see a large population of women with breast cancer is, which we'll get later on throughout the talk today, or our conversation, is that when women are treated with surgery and radiation and chemotherapy, obviously the goal is to shrink the cancer cells, which is great. But a potential side effect could be that the cancer drug can affect the heart, right? Because when we're getting chemotherapy in our veins, it's not only going to the cancer cells in your body, but it's going to your heart. And what'll happen is if the patient is getting the treatment and suddenly he or she starts describing to the doc, you know, I'm getting short of breath. I can't climb up a flight of stairs anymore. I'm going for a walk with my dog and I'm just winded. I got swelling in my legs. And what the cancer doctor will do is say, okay, there's just something not right here. They'll do a couple of initial tests, but eventually those patients will be referred to me to see what's the diagnosis. Is there actually injury to the heart? How do we make that diagnosis? And then most importantly, how do I treat it, right? Because at the end of the day, I don't want to have my young 28-year-old mom, 2 kids, gets cured from her breast cancer, but then has a side effect where she develops injury to the heart and have heart failure. And you don't want to exchange, I guess, one disease for the other. So that's where we're working collaboratively on that.
That's great. I would like to just take a moment to poll our audience. I'm just curious about how much discussion they've already had around heart disease with their oncology team. So I'm just going to do that right now. I'm going to launch a poll. Okay. And so hopefully you're seeing that on your screen right now. And the question is, did you ever discuss heart health with your treatment team after your cancer diagnosis? So we'll wait a moment for some results to come in, and then I'll get you to comment on that. And just while we wait for the results, I had a question because you mentioned about one of the symptoms being shortness of breath. Can shortness of breath during cancer treatment be related to something else aside from heart issues?
Oh, 100%. So when patients come in with shortness of breath, you know, the 3 main causes of shortness of breath is either your heart, your lungs, or the blood that's actually carrying the oxygen. And the blood that's carrying the oxygen, I make it akin like the taxi cabs that are driving throughout your blood. And so most commonly when patients with cancer are receiving their chemotherapy and their blood counts are low, they'll get short of breath because these taxis are getting affected by the chemotherapy. However, if it's not your blood test or your blood count that is low, Then other causes could be whether it's the heart itself, where you develop heart failure, where your heart, which is basically a pump that pumps blood to the rest of the body, like the engine of your car, suddenly becomes weak. That could be a cause of the shortness of breath. And then the other cause for the shortness of breath, Kathleen, could be your lungs, because when one receives either radiation or they receive chemotherapy, one of the side effects potentially could be some injury to the lungs. So those are the big three categories when I see a patient of shortness of breath. Is it the taxis, the blood in your body that's been affected by chemo? Is it the heart that has been affected, where the pump or the engine is no longer working, you've developed heart failure? Or is it potentially your lungs that has been affected?
Okay, thank you for clarifying that. I'm going to end the poll right now and share the results. So if you weren't able to see that poll on your screen, it may just be that your computer doesn't support it. So you can always send a message to Ellie also in the Q&A, and then she will relay your comment to us as well. So Dr. Jassal, can you see those results there?
Yeah, so, did you ever discuss heart health with your treatment team after cancer diagnosis? I think we have about a quarter says yes, it was discussed. A half says it was not discussed, but like to know more. And then 22% it was not discussed because they didn't think it was considered relevant.
Mm-hmm. So do you think that that's fairly typical for cancer patients, that it's, only in a quarter of situations it's sometimes, well, I guess possibly there's another 25% where 22% where it wasn't considered relevant. Is it always relevant or?
Yeah, no, I think those are, I think this is quite reflective in terms of maybe the quarter of the population saying that, yeah, it was discussed.
Mm-hmm.
If you think about it, when you go see, I'm going to use the analogy, when you go see your GP, your family physician looks at you as a patient as a whole. And when you describe symptoms that you may be experiencing, they're going to be looking at you from a cancer perspective, from a lung perspective, from a heart perspective, as the whole patient. I think when you go see a specialist, say myself as a cardiologist, or you see a nephrologist, a kidney specialist, or a cancer care Manitoba specialist, once we specialize, we often, have our vision or tunnel vision. We focus on that specific organ. Why? It's because we're the experts, right? So if you're coming to my office and you're saying you have some foot pain, the foot is pretty far from the heart, and I probably don't have an answer for you. But if it's somewhere in the chest, obviously I'll be able to help you out from the heart perspective. So I'm not surprised with that. I think lots of education is important for specialists to know that when we see patients, even as a heart doctor, I should be thinking outside the box and looking at everything as a whole. And I think I can say that with this whole, I'm going to call it explosion of cardio-oncology, where our patients know about it, our physicians, cancer doctors, and cardiologists know about it, you're going to hear more and more, where your cancer doctor is going to say, by the way, can you tell me a little bit about, do you have risk factors for heart disease? Do you have diabetes, high blood pressure, smoking, family history? So they're going to start taking more of that history. Similarly, for myself as a cardiologist, as opposed to just asking patients, do you have chest pain, shortness of breath, and heart fluttering, I'm starting to ask other questions outside the box. So have you lost any weight? Have you noticed any blood in your stool or vomiting up blood? When you're sleeping at night, are you sweating and notice that your pillows are drenched with sweat? So I think the specialists are doing a better job of going outside their field. Obviously, I'm not a cancer doc and I'm not pretending to be one. And if I feel that there's anything in my history taking that tells me that this patient should be seen by a cancer doc, or the cancer physician feels that this patient should be seen by a cardiologist, I think that's super important.
Yeah, definitely. There was just a comment in the Q&A that somebody mentioned that it was only addressed as a possible side effect. So that, and that's a big side effect, I would think, of having possible heart disease. Or
yeah, I think I can address that by a comment that for the patients who are in the Zoom webinar today, if any of you for your breast cancer, your lymphoma, sarcoma, ever received a chemotherapy drug called doxorubicin or anthracycline, how I explain to patients if they don't know the names, I said, do you remember the red Kool-Aid? So when you come in, you have your cancer medication administered to you and you see the bag and it looks like red Kool-Aid. I'm aging myself if everyone remembers Kool-Aid back in the day. And so anthracyclines, doxorubicin, are medications that are used to kill the cancer cells, and they do a great job of that. But we know, even going back to the 1970s, that the canthrocyclines or the doxorubicin can actually get into the heart and cause the heart to become weak. And so all of your cancer doctors who you work with will actually mention that to you and say, Mrs. X or Mr. Y, this is a drug that's great for helping get rid of your cancer, but there is a side effect where it can injure the heart. They'll give you hopefully a percentage of what that risk is. And I think majority of you know that to prevent you from having any injury to the heart, we have to do a test on your heart to see how the heart is pumping, right? And so what you'll have done are one of two tests. One's called a MUGA scan, MUGA, or the other one's called an echo, ECHO. Both the MUGA scan and the echo, which is just putting some ultrasound gel on your chest, these two tests allow us to see how the heart is pumping. So before you receive your chemotherapy, you'll get a MUGA or an echo, and it'll tell me what your heart is pumping before you start any medication. And then every 3 to 6 months while you're receiving the chemo and the radiation, you'll actually get these tests done to see what happens to your pumping function. And if the cancer doctors and the family physicians know that your heart pumping function is starting to go down, they get concerned that you are developing some injury to the heart, and then you come and get referred to myself to see how can we do to prevent this from happening, and how do we protect your heart to make it come back to normal.
Okay, so just to clarify, is that for only these specific chemotherapy drugs, or is that for chemotherapy in general?
It's only for those chemotherapy drugs that I mentioned, the anthracyclines. There is a whole plethora of chemotherapy drugs, but the cancer doctors and the heart doctors in collaboration, we've identified, the ones that are very high risk to cause injury to the heart. And I think the two most common ones that perhaps the patients, individuals who are on the Zoom call know is, one is doxorubicin anthracyclines, which is the red Kool-Aid. And then the other one that we use in women with breast cancer is something called Herceptin. And Herceptin is a medication you get every 3 weeks for a year. So those are the two medications that cancer care doctors know very well, that once you get started on them, we have to do testing of the heart, which they'll take care of, just to make sure there's no injury to the heart.
Okay, so just before we continue a little bit, there's a couple of questions that relating to some things that you've talked about. So somebody mentioned that that they do have shortness of breath, and they checked oxygen levels were okay, said it could be anxiety, and they were recommended to exercise. What are your thoughts on that?
No, I think it's a great question. So remember, when patients come in shortness of breath to their family physician, cardiologist, specialist, anxiety is my diagnosis of exclusion. I will only say that it's an anxiety issue if I haven't ruled out anything that's objective. So if you're referred to myself, for example, you said your oxygen saturation is fine, that's okay, but I still need to rule out those 3 big causes. So if you come to see me with shortness of breath, or you get seen by a specialist, I'm going to look at your blood count, the taxes. Hemoglobin is what it's called in medical terms. And the hemoglobin in women are often about 120, and for males, it's 140. And if your numbers are 120 or 140 around that area, I know it's not your blood. You're not anemic, your blood count isn't low. So that's off the table. The second thing we'll do is we'll do a quick picture of your heart, an ultrasound where we put a jelly, and just see how the heart is pumping, like the engine in your car. And if the pumping function is completely normal, then that's taken off the table as well. And then from the lungs perspective, what often, and I'm not a lung specialist, but my respirologist, so these are lung specialists, will do, is they'll do a couple of tests on your lungs just to make sure your lungs haven't been affected by the chemotherapy or the radiation. One, you'll get an X-ray likely, so you sit in front of a camera and it takes pictures of the lungs. And then the other thing you might have done is where you breathe at the end of this sort of vacuum tube that tells you how the lungs are, and you blow out of it. And some people have had these kind of tests done. I guess, Kathleen, after the blood test is negative, the picture of the heart is negative, and the X-ray and these tests that the lung special are negative, then if I can't find anything objectively wrong, explaining why you're short of breath, then perhaps it's anxiety. And I don't use the word anxiety, but I use the word called deconditioned. Deconditioned is the fancy word where in the COVID world, all of us were sitting behind the camera, which we're still doing right now, although we're starting to move now, which is great. watching majority of Netflix reruns and watching Game of Thrones, and we call it the pandemic extra pounds, right? Majority of us gain about 10 or 15 pounds. So deconditioning means that I always tell my patients, I need you to exercise 30 minutes a day, 5 days a week. And I don't have time to do that. If you have time to watch Netflix, you can put yourself a treadmill in front of your Netflix and watch it. So that's how I would approach the shortness of breath question.
Okay, thank you. Another patient has mentioned that they had some night sweats as a side effect of anti-estrogen pills. They were wondering if that could also be a heart issue.
Yeah, technically, no. It's a common side effect that you may have with the pills that you had mentioned. In terms of night sweats, I would only be concerned about them, and particularly if you're having heaviness in the chest at the same time. So for my male patients, if they're having sweats, it's not so much at night, but it's when they're exerting themselves. So they say, Dr. Jassal, I'm walking 10 feet, and then I have this elephant sitting on my chest and I'm sweating, then I'm concerned that you have a heart-related issue. Women, we remember, are a little more have atypical presentation, so they don't have the typical chest pain, someone sitting on their chest. They may say, I have a bit of jaw discomfort, my shoulder hurts. One common question I always ask women who I'm concerned that they have chest pain due to the heart is if they have a tight bra sensation, so that they feel that there's something there. But sweats at night alone, I'm not concerned that it's related to the heart.
Okay. Another question, somebody's currently on, and correct me if I'm wrong in this pronunciation, Tagrisso.
Okay.
And I'm wondering how often I should be getting my heart tested because of possible heart damage from it.
Yeah, so in terms of the medication themselves, what I would recommend you chat with either your family physician or your oncologist and ask them if they could potentially just order an echo and ultrasound of the heart just to see how the heart is pumping. If you haven't had one at baseline, perhaps just having one done now while you're on the medication just to make sure that the heart is doing well. The wait list for either a MUGA scan or an echo in our province right now is only about 4 to 6 weeks. It used to be longer. I'm talking about 3 to 4 months in the pandemic, but we've really caught up. So I think asking your family doctor, can I have an echo, ECHO, which is an ultrasound of the heart, or a MUGA, MUGA, and that will be able to help us identify if the heart is pumping okay.
Did you explain what a MUGA was already?
No, it's a good, no, I haven't yet. So if we can spend a second for that.
Sure, yeah.
Echo is easy. Give me 10 seconds here.
Sure.
I'm going to bring my echo machine here. So here's show and tell. I love it. This is like Mr. Dress Up here. So this is what an echo machine looks like. This is a portable echo and ultrasound of the heart, where what I do is I put a bit of gel here. I put this on the patient's chest, and then I can look at this nifty screen here and actually see how your heart is pumping. Now, this is just one that a heart specialist will use in the office. And if I see something a little abnormal, then you're going to have a full-fledged echo, which means we use a machine that's the size of a refrigerator and spend 45 minutes and get some good pictures. So that's what an ultrasound is. A MUGA is a test that we do also in Manitoba. What happens there is the docs will basically get some blood from your veins. They'll put a specific radiation tag to it, and then you're going to lie in this camera, which looks like a donut, round donut. Majority of patients on this call who've had a CT scan, it's the same thing. And what it does, Kathleen, it tells us how the heart is pumping. So we either do a MUGA or an echo, depending on which test can be done sooner.
Okay, great. Another question, somebody asked, does tamoxifen affect the heart?
Yeah, it's a great question. I think the jury is still out there. We don't know the answer to that, because majority of patients after they've been treated for their breast cancer will be on tamoxifen for at least a year or two after for treatment. And when I review the literature of late, I've not seen any significant increase in terms of the risk of having high blood pressure, heart attack, stroke, or heart failure. So in terms of whether you should be continuing the medication, the answer is yes for now. And I guess stay tuned. We still don't know the answer of whether there's any detrimental effects of tamoxifen. In my mind, when patients come and see me and they're on tamoxifen, I continue them on as is.
Okay. So a couple questions relating to radiation and how radiation might impact the heart.
Sure. So in terms of radiation has really advanced over the past 20, 25 years in the sense that when we looked at radiation back in the 1970s, we knew obviously the heart is in the lungs, so it's in the chest here. And what would happen is the patient would go into the scanner and you'd be radiated, but the entire body would be radiated. Now we've become very astute to knowing that you want to make sure you protect the heart. So if any of you have received radiation therapy as part of your cancer treatment, what you'll notice has happened is that you're going to get just a select area of your body that gets exposed to the radiation, and they try to avoid the heart. And if your cancer is around the heart, then they're going to try signaling the beam there. So that's one thing that's been great about radiation. The comment, however, about why I'm explaining this, Kathleen, is that when you had radiation given back in the 1970s throughout the entire body, what radiation can do is it can do two things. One, it can cause hardening of the arteries. So in your heart, the heart is my fist. We have three pipes that supply the heart, one on the front, one on the side, and one in the back. And if any of those pipes ever get blocked with cholesterol and plaque and stuff, you'll actually have a heart attack. So that's what a heart attack is. It's a blocked pipe that supplies the heart. And what happens is if you had radiation back in the 70s, less likely nowadays, it causes hardening of the arteries to actually accelerate. So that happens a bit quicker. So that's one concern with radiation, is hardening of the arteries that gets accelerated. And the number two is in terms of the heart itself, if this is my heart, everyone has this covering or layer around the heart. Fancy word is called the pericardium, pericardium. And what the pericardium is just saran wrap around the heart. And what can happen with the saran wrap if you get radiation is the saran wrap can get actually quite thickened, and it can prevent the heart from actually doing its job. And so the reason this is important is that I'm seeing now patients who I call childhood survivors, meaning that they were diagnosed with cancer, early in their teenagers years, so anywhere between 8 and 20. They received chemotherapy, but they received a fair amount of radiation back in the 70s. And now, 40, 50 years down the road, they're coming to myself and they actually have symptoms of either hardening of the arteries or chest pain, or they have this issue where the saran wrap around the heart has been affected by the radiation that they received years ago.
This is a question that I'm going to stumble over some of these words, but someone's mentioned that they're on an HER2 chemo, and one of their tumors is on their sternum. So they've been having some chest pain, no swelling or sweating. Oncologists did a MUGA and said all is normal. Someone suggested it could be costochondritis, right?
That's okay. You're doing great, Captain. I'll take over their costochondritis.
Thank you. You saved
No
me
worries.
there. Is there a certain test that would be recommended, and can this person be referred to you?
Sure. I feel like Dr. Oz here in terms of explaining all these things. This is wonderful. So in terms of your cancer, if it is involving the sternum, for the audience, the sternum is this bone that's behind my blue tie here. So it's the breastbone. If there's cancer involvement there, the question is, is it affecting my heart, or is it something that's related to where the ribs go into the breastbone? If your cancer doctor has done the MUGA scan and the MUGA scan is normal, then we know it's not your heart at all, because the pumping function is normal, which is great. And that's the first test I would have ordered. Costochondritis, which is this fancy word, basically involves the ribs that are going into the sternum themselves, or which is your breastbone. And that's just a bit about inflammation. So imagine you're going to yoga, or you're doing a Peloton class, or you're playing football and you hurt yourself with the ribs. That's what costochondritis is, which is chest wall pain. In terms of how you make a diagnosis, unfortunately, there's no tests, so fancy schmancy tests to make the diagnosis. It's more by excluding other causes. And then in terms of treatment often involves anti-inflammatory, so like Tylenol, naproxen, to see if they can improve the symptoms. In terms of the referral to myself for that, I wouldn't be able to provide any more information than what I just shared with you, just because if your heart pumping function was decreased, that's where I'm definitely able to help you. But if it involves the chest wall itself and it's related to the ribs going to the breastbone from the cancer itself, unfortunately, I don't have much to offer as opposed to what I just described in terms of decreasing the inflammation.
Okay. Just going back to the discussion that we're having about the radiation in this area, and for someone that has lung cancer, they've asked, is the radiation for their lung cancer going to affect their heart?
No, and it might. It depends, right? If you're fortunate that the lung cancer is actually on the right, so everyone's heart is located on the left side of the chest. So this is my heart, and this is my breastbone over here underneath the thigh, and it's the left side. If you happen to be fortunate that your cancer of your lung affects the right lung, then yes, the radiation is going to be focused there, and they're going to make sure they protect your left side of your heart. However, if you do have cancer that involves the left side of the heart or both lung fields, then the heart will be likely affected by the radiation. Can't prevent that from happening. But we have to think about it at the end of the day. The radiation is going to be very important to shrink the tumor size itself, right? And in terms of these side effects that I mentioned of radiation, of affecting the saran wrap around the heart or causing hardening of the arteries, that doesn't happen overnight. That happens 10, 15, 20 years down the road. So at the end of the day, if I'm 55 and I have lung cancer and it's involving my left lung, by all means, I want that radiation to shrink that tumor, the cancer itself, so that I can increase my longevity, knowing that there is a risk, not 50, 100% risk, but probably up to 2-3% risk that when I'm in my 70s, that maybe it's caused some hardening of the arteries or affected the saran wrap.
Okay, so lots of questions about different types of drugs and the impact. So a question about androgen deprivation therapy. Is there any relationship between that and heart disease?
Yeah, in terms of androgen deprivation theory, effects on the heart, the answer is no. In 2022, I can tell you that if you are taking it, so for deprivation, the answer is no. But if you are taking exogenous androgens, then there has been an effect on the heart. What I mean by that is we obviously know in terms of the audience here that if you go to the gym and you take steroids, for example, another family of steroids are if you take androgens, which are called growth hormone. And these drugs, although they cause you to bulk up and increase your muscles, they can also affect the heart itself because the heart is a muscle, so something to remember. So often patients who develop or receive exogenous androgens, which means they're injecting themselves with growth hormone, can affect their heart. But in terms of deprivation itself, I haven't seen anything in the literature for that.
Okay. A question about docetaxel, whether that has any effect or risk?
Yeah, so great question. So docetaxel is one of the chemotherapy drugs that is used in patients with breast cancer particularly, but it actually doesn't affect the heart itself. So majority of patients who get treated for their breast cancer, if you're getting chemotherapy, there's a number of drug concoctions that you would receive. If it includes the anthracycline or the doxorubicin, that red Kool-Aid, yes, that affects the heart. If you happen to receive docetaxel, though, which is a separate class of drugs, it has not been shown to have any detrimental effects to the heart.
Okay. Another drug, this is really testing me today, doxorubicin.
So that's what we just mentioned, Kathleen.
Okay,
doxorubicin and anthracycline is the Kool-Aid. So that definitely affects the heart.
That one is, okay.
And because we know it affects the heart, that's why your cancer doctor will always order a MUGA scan or an echo before you get that doxorubicin, which is the Kool-Aid.
Okay, great. Eliquis and Pina metropropyl.
That's okay. So Eliquis, Eliquis, metoprolol. What's the question though? I can't see it.
There's any, just if there's any effect or risk to the heart.
Can you
specific to that? Yeah, specific to that. Eliquis and Pina metropropyl.
Okay, that's all right. So I'm going to guess the question here because those are the two medications that I know that are used for a condition. So if the patient who's asking that question, Eliquis and metoprolol, does it affect the heart? No, it helps you prevent you from having a stroke. So in terms of the heart itself, you have the top part of the heart and the bottom part of the heart. As we all get older, especially over this magical age of 65, you can develop an irregular heartbeat, and the irregular heartbeat is called atrial fibrillation. What irregular heartbeat does is that the top part of the heart quivers. And as we get older, the reason it starts to quiver is we just get a stiffened heart. So if you ever go see your family physician, your cancer doctor, and they label you with this atrial fibrillation or irregular heart rate, what the docs will do is they'll start you on this medication you mentioned called Eliquis, which is just a super aspirin. They'll also start you on the metoprolol, which is a pill that you take twice a day that slows your heart rate down. And the reason they put you on those medications is to make sure you don't have a stroke. Because when you have this quivering heart that's not pumping efficiently, that increases the chance of blood starting to clot in your heart. And if a blood clots in your heart and it decides to go up to your brain, then you have a stroke. So that's why you're on those two medications.
Okay, so those medications are heart medications, not cancer medications.
100%.
Thank you for clarifying that. Somebody also asked about Zoladex injections that they're taking every 3 months plus radiation.
Yeah, in terms of radiation, as I mentioned, in terms of hardening of the arteries, as well as the saran wrap, but in terms of Zoladex, in my cardio oncology clinic for the past 20 years, I have not seen any effects on the heart.
Okay, and another question about our atrial fibrillation and arthritis in upper chest. I guess the question was that they're also having radiation.
Okay, so again, with the atrial fibrillation, the irregular heartbeat, you would be treated with a blood thinner to prevent you from having a stroke. Of interest, when you had mentioned rheumatoid arthritis, we have actually seen of late in the literature that arthritis, patients with rheumatoid arthritis or lupus, for example, these are conditions that you're born with where your body decides to attack itself. You are at a higher risk of developing some hardening of the arteries over the years. So patients with rheumatoid arthritis are at increased risk. And then if you had mentioned that the patient also has radiation as well, then obviously we've already gone through that before about the saran wrap and the hardening of the arteries.
Okay, great. Thank you. More questions. This is great. Yeah.
That's okay.
This person, except for the pronunciation, that's not okay. This person mentions that they had a MUGA before their first ABVD and an echo before radiation for lymphoma relapsed in. How frequently should these be done?
Great question. So the MUGA scan that you had mentioned is telling me how the heart is pumping before I start the chemotherapy. That fancy term you use of ABVD are actually 4 different cancer drugs that we use as a concoction together. Of the ABVD, one of those is actually the anthracycline that we talked about, the red Kool-Aid. And so after you've had your baseline MUGA scan before all the chemotherapy starts, often if you ask the cancer docs, they're going to give you anywhere from 4 to 6 cycles of the chemotherapy, which are given over, say, 3 to 6 month period. I personally would like to see a MUGA scan done at month 3, and then a MUGA scan done at 6 months after you've done the chemotherapy, just to see serially, which means at baseline, 3 months into your chemotherapy, and then once you're finished, just to see if the numbers of the pumping function of the heart stays the same.
Okay. This person also had a question about should they continue to exercise if they are having shortness of breath and some night sweats and some swelling in their legs. They're mostly doing yoga, but should they continue with their exercising?
I think that's absolutely super important. I think a myth that we created back in the day, in the 1970s and 80s, when you came into the hospital with chest pain and had a heart attack or you had heart failure, we ended up basically putting you into the hospital, giving you some morphine narcotics and say, just bed rest, don't do anything. That is old belief now. I have heart failure patients who have a weak heart, whether it's due to chemotherapy or other causes. And the number one thing I explain to all our patients is exercise, exercise, exercise. Exercise is so important because it allows the blood to flow to the body. And again, 30 minutes, 5 times a week. 5 times a week seems, unreasonable, even 3 times a week, but exercise is super important. And I think one thing after the questions, Kathleen, if we can come back to how exercise is super important regarding our research study we're doing with women with breast cancer, I think that'll be important we talk about that as well.
Yeah, definitely. Let's do that. Just a couple more questions about people's treatments. So asking about letrozole and any cardiac concerns for postmenopausal women. Yeah,
so similar to tamoxifen in terms of letrozole, you'll often be treated with letrozole after you've been treated with your breast cancer for at least up to 2 years. And again, looking at the literature in terms of the science, there is no strong evidence that letrozole causes any heart effects. So I have patients on that who've been prescribed by the cancer doctors, and I'm okay with that drug.
Okay. And this person's also asking, or a different person's asking about a stem cell transplant. Can it increase the damage to heart?
Yeah, so it's a great question. In terms of stem cell transplants, so for patients who get stem cell transplants either from their own body or from family members in terms of their siblings and so forth, obviously the utility of that is to help with curing your cancer and putting you in remission, if you will. In terms of causing any injury or damage to the heart in terms of the pipes or the pumping function, the answer is no, unless they're starting to use some of the cancer drugs at the same time. But I have not seen any concerns with autologous stem cell transplants causing injury to the heart.
Okay, so it may just be if they're receiving, because this person's also receiving some extensive chemotherapy, they said.
And I think that would be more of the concern if it happens to be one of the Kool-Aid drugs.
Okay, let's quickly launch our second poll if we can. So this one is just asking our audience about risk factors, because it's a complicated relationship between cancer treatments and heart disease, because I'm guessing that there may be risk factors similar for heart disease as they are for developing cancer, and knowing if one has caused the other or not, it must be tricky. So let's just do a quick poll here and see if any of these risk factors pre-existed your cancer diagnosis. So if you could take a moment and look at these risk factors, and then we'll get into that, and also about the research that you're doing around flaxseed. That's really fascinating. This hour is going by very quickly.
Good. And you're becoming an expert in terms of medical terminology.
I would say that's far from the truth.
I was going to say we'll make you a cardio-oncologist by the end of the hour, and then I'll have a partner in crime.
But thank you for being kind.
And for the folks that are in virtual world, really appreciate you asking these questions. These are super important questions, and thank you for coming.
Yes, definitely.
But please don't leave yet.
No, we've got 20 more minutes. So there are some more specific questions. Maybe we'll leave some until if we have time towards the end,
Sure.
and then we'll just continue on with some of the research that you're doing as well. I'm just gonna give a moment more for this poll. Let some more results come in. Okay, I'm just going to share the poll right now. We just have just over half the people that have participated in that. So are you seeing the results there, Dr. Jassal?
Yeah, so we have about 14% who had smoking as a risk factor, 29% is obesity, 33% having the McDonald's unhealthy diet, nothing against McDonald's, 55% of physical activity, and 38% for high blood pressure. So, majority of the patients had at least one of the traditional risk factors for heart disease.
Prior to, yeah.
Yeah.
So how does that, in terms of the research around cancer treatments and heart disease, it must be difficult to ascertain whether or not it's I suppose the treatment could exacerbate an underlying condition that was already there, prior to the cancer diagnosis.
Yeah, that being said, though, the risk factors that we just talked about are obviously the traditional ones that we think about for the big three causes of death, right? So heart disease, cancer, and stroke. And so anytime you see a neurologist, which is a doctor who deals with strokes, a cardiologist for heart, or a cancer doctor, we're going to ask you all those risk factors of, do you have high blood pressure? Do you have diabetes? Are you a smoker? Do you have a family history of heart disease? And what's your activity level? And those are common risk factors for developing one of the three diseases. One of the things that's interesting, Kathleen, is that when I moved back in 2006, and I started the cardio-oncology clinic, one of our earlier research studies that I did was I wanted to see in women who were receiving the Kool-Aid, the anthracycline, what's the chance of them developing injury to the heart from the cancer drug? Now, when you look at the clinical trials, so all the trials that were done in early 2000, they said that the chance of a woman with breast cancer getting chemotherapy, doxorubicin, Herceptin, which you mentioned earlier, is about 1 in 10 risk of developing injury to the heart. But when we looked at our Cancer Care Manitoba database and looked over 200 women over 5 years and seen what it was, the risk was, and it was actually 1 in 4. So the risk wasn't as low as 1 in 10, it was higher. And the reason it's higher is that when you go into a clinical trial, these are often healthy people, they don't have any risk factors. And so we teased it out a little bit further and said, the women with breast cancer who are developing injury to the heart, was there something unique about them compared to those who weren't having any damage to the heart? And we found that patients who were smokers in the past or had a family history of heart disease, which means that their mom, dad, brother, or sister had heart disease before the age of 50, they were more likely to develop injury to the heart. So one thing you may notice, if your cancer doctors are asking you questions about your heart, they're going to ask you, are you a previous smoker? Are you a family history of heart disease? If they don't ask you, if you end up on my door and I ask you the same questions, we know that these two factors do predispose you to have injury to the heart earlier than someone who doesn't have them.
Right. So in terms of prevention, people that have had a cancer diagnosis, can they still, early on make changes to their lifestyle that would benefit them in terms of not developing heart disease, also perhaps preventing reoccurrence of their cancer?
So I'll answer that 2 ways. If there's anything that you can do if you get diagnosed with cancer or heart disease and you're a smoker, please put the cigarettes away. I can give you multiple medications from the heart perspective. My cancer colleagues can give you multiple chemotherapy. But if you put that cigarette away, you're going to increase the longevity of your life. That's number 1. Number 2 is exercise is super important to your chemotherapy regimen. And one thing that I'm going to share at this point is that we're currently doing this fantastic study called the EXACT study, EXACT. Anyone in this audience here or who has family members who've had a heart attack, if you've had a heart attack and you come to St. Boniface and we fix you up, what happens we do is we send you to cardiac rehab, which means you go to the wellness or you go to Seven Oaks or you go to the refit on Taylor and you do what's called cardiac rehab after you've had the event to make sure that you don't have one in the future. In cancer patients, what we're doing is we're doing the same thing, but I think one thing would be really important is could we do something called prehab? Prehab means before you get the chemotherapy, could we actually really strengthen the heart so that no effects happen to you when you get the chemotherapy? And so we've been doing the EXACT study with our colleagues and Dalhousie in Halifax. We've done it for 2 years now. And what happens is if a woman gets diagnosed with breast cancer, so she has a mass in her left breast, she calls the family doctor, they do the mammogram, it's positive for breast cancer, and you see the cancer specialist and they're going to start you on chemotherapy and radiation surgery. The cancer doctor will actually refer you to me if you're interested in study. And what we do is we will randomize you, which means you get put into 1 of 2 arms. One arm is you just get your chemotherapy and you do your usual routine. The other one is we actually have a personal trainer who will actually make you exercise 3 to 5 times every day while you're getting chemotherapy radiation. All the women have fancy Polar devices or Apple Watches. And what I'm doing is I'm following them for a total of 1 year to see if you're getting lots of exercise while you're getting the chemotherapy, are you less likely to develop damage to the heart? And I think that's super important of how useful exercise is to prevent any injury to your heart.
Yeah, that's super interesting. And can you tell us a little bit about the study and the research around flaxseed?
Yeah, flax milk I'm super excited about this. So everyone knows, I hope you know that when you're having your cereal in the morning, and not your Fruit Loops, but you're actually real cereal, you get a couple of teaspoons of flax and you throw it onto your cereal. We know the benefits of flax on your heart. In about 10, 15 years ago, they've done some studies that show that if women were taking flax supplementally, it actually helps with the treatment for your breast cancer as well. So if you're getting chemotherapy, your cancer cells can shrink with flax. So we know that flax is great for heart disease. We know flax is great for shrinking cancer cells as well, with chemotherapy, that is. What we wanted to figure out is if when women are receiving chemotherapy, the red Kool-Aid, that doxorubicin, can we protect the heart from the damaging effects, the potential damaging effects? So we've been doing this study called the CANFLAX study, CANFLAX, CANFLAX. Cardiologists, all we do is we sit in a room and we make acronyms every day. But the CanFlex study is really neat because I was able to team up with one of my colleagues here in Russell, Manitoba. I'm a small town kid, Thompson, Manitoba, but Linda Pizzi, P-I-Z-Z-E-Y. Pizzi Ingredients is actually the world's largest flax producer, not Canada, world. And you think Russell, Manitoba, but that's what it is.
Yeah.
And I asked Linda, instead of putting, teaspoons onto a cereal for a patient to take, especially when they're getting chemotherapy, can I convert it into something that they can drink? So we have a study where we have women with breast cancer before she's getting chemotherapy or radiation. And you come into our study, we randomize you, which means put you in one arm. Either you're going to get a placebo milk, which is oat fiber milk, or you're going to get flax milk. And while you're getting your chemotherapy for 4 months, we're going to keep asking you to take this flax milk. And the theory, or what we're trying to figure out, Kathleen, is for those women who are getting the flax milk, are they less likely to develop damage to the heart because the goodness of the flax that's in the milk is actually getting into your heart, protecting it when you're receiving the chemotherapy? So super excited about the exercise study we're doing and the flax milk, if you will.
Great. And have there been any early kind of results from those studies that at this
No,
point?
unfortunately, I can't share them with you just because both of them started 2 years ago. We were slow to start because of COVID, obviously, in terms of the restrictions. But as we are coming and loosening restrictions, we have more patients that are being enrolled in the study. Both studies require 1-year follow-up. So we are now in 2022. I'm suspecting by the end of December next year or early 2024, stay tuned. Maybe I'll be invited back again and I can give you an update of how good flax milk is and how good exercise is.
Yeah, super. I know there's a couple other drug-specific sort of drug questions that people have, and I'm just wondering, we may not get around to all of them. And is there a website or anywhere that people can go to learn more about the link between their medication and the possible effects of it?
Yeah, I think that, so you have to be very cautious when you go into the internet because you can find anything about everything.
Exactly.
So one thing I would advertise for everyone is that when I see patients in my clinic, the two things or sites that I ask them to do is go to just Google cardio oncology. So cardio, I probably can't type it you can only see it in the chat box just for host and panelists, correct? But if you can just share with the audience, cardio, C-A-R-D-I-O.
Okay.
And then oncology, O-N-C-O-L-O-G-Y, cardio oncology. And maybe Allison can write that, or
Allie's doing that.
Yeah. So Allie, cardio, C-A-R-D-I-O, hyphen oncology, O-N-C-O-L-O-G-Y. Just type that in and you'll find some great sites in the US and Canada in terms of what it's all about. The other thing also, Allie, if you want to put in the chat boxes, there's this fantastic meeting that happens once a year for both doctors, scientists, and patients. It's called the Women Heart Health Symposium. So the Women Heart Health Symposium is being held in BC, British Columbia next year in the spring. And if you go visit Cardio Oncology or Women's Heart Health, you'll be able to find out more of this information.
Okay, that's great. Yeah, that's super because I just want to, I'm trying to get to everybody's questions and we may end up missing a couple, but somebody else also asked about specifically about lymphoma patients. Is there anything specific for lymphoma patients that they should be aware of?
Yeah, for patients with lymphoma, you will often be treated with that anthracycline, that doxorubicin, the red Kool-Aid, as one of the concoctions in terms of your chemotherapy. So ideally, you should have had a MUGA scan done or an echo before your treatment and then afterwards. In terms of lymphoma patients, I often see childhood survivors. So they've had either lymphoma or non-Hodgkin lymphoma when they were between the ages of 6 and 18. They received their chemo, they received their radiation, and now 30, 40 years down the road, they come and see me. So lymphoma patients are at risk of heart disease, not so much from the cancer itself, but it's from the treatment, whether it was the Kool-Aid or the radiation they received.
Okay. This is a question from a patient, a breast cancer patient, had an EKG just on September, and she said the results were 474 over 485, said significant changes have occurred. She's wondering if that's concerning. She's 55 years old.
Sure. So in terms of that QT number you're sharing with the entire audience, That refers to your EKG, which is your heart tracing. So if you ever go see your family doc or your cardiologist, and we put stickies on your chest and we hook you up to a little machine, that just tells us the electrical activity of the heart. The QT is just a special length in terms of how the heart rhythm is doing. In terms of QTCs, if it's 470 at baseline to 480, I wouldn't sweat it. I'm not worried about that. I get concerned if it's about 500, 510.
Okay.
Then any number above 500 gets me concerned. So I wouldn't worry about 475 to 480. The other thing also is the breast cancer treatment you're getting, if you are receiving it, really doesn't affect that number per se. There are a lot of over-the-counter medications that we can take that can actually cause your QT to get longer. So cough suppressive medications, Benadryl, and so forth. So if your QT is getting a little bit longer at 480, I wouldn't be concerned about it unless it goes above 500. But maybe sit down with your pharmacist or your GP and just go over the medications you're taking, both prescribed and over the counter. So if you're on ginseng, shark cartilage, something weird and wonderful, mention it to them just to make sure it doesn't affect your QT.
Okay, great. Just another question somebody had about some, I guess, controversy around flaxseed, being told not to take flaxseed because they're PR and ER positive breast cancer patient.
Yeah, I don't know in terms of where the controversy is that, because when I review the literature, we know that flax is really important for patients, not only to decrease their breast cancer size when they're receiving treatment, but potentially also protecting it from the damaging effects if it gets affected by the cancer drugs. So I haven't come across the literature of reading that flaxseed is detrimental to patients who are, as you had mentioned, ER positive and PR positive for your breast cancer.
Okay, so there's, yeah, so that the idea of not being able to take it, that's not, you're not sure where that comes from. Yeah.
I don't know where it's come from. I haven't seen anything in the literature for that.
Yeah.
No.
Okay, great. Okay. Two more questions if we can get to them. One was about monoclonal antibodies, and it's a CLL patient.
Sure.
And is that, I guess they're concerned about maybe the risk of heart disease.
Yeah, no, it's a great question. So for patients with CLL, CLL for the audience is chronic lymphocytic leukemia. When we hear leukemia, we worry about it being very aggressive, but that's often in young children when they have ALL, which is acute leukemia. This is more chronic in the elderly patient. I'm going to call myself elderly as well as we get older. But in terms of these new monoclonal antibodies, they've actually been shown to be great for treatment of CLL. There's a very, 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 I'm going to use the word very again, low risk of causing some irritation to the heart. There's this heart condition called myocarditis. MYO is the heart. Carditis means inflammation of the heart. And some patients can develop some irritation or inflammation of the heart from the monoclonal antibody. I can tell you, I follow close to 2,000 patients in Manitoba who've received chemotherapy from cancer treatment, have had some injury to the heart, and the majority have recovered. Myocarditis, which is the inflammation of the heart due to a monoclonal antibody, I may see maybe 2 or 3 cases a year. So it's very, very infrequent.
Okay, great. A couple more questions about flax. Somebody was asking whether they can take it during treatment or they should wait until after treatment, and also asking if they can take whole flax or whether they should be, is it possible for other people to buy flax milk?
Yeah, so it's a great question. So in terms of treatment, as long as you can tolerate the flax and you're not getting super nauseated, obviously, from the chemotherapy, I would, encourage you to do that. In terms of the flax milk, when I speak to Linda Pizzi, I don't know if it's actually hit the shelves yet at Superstore or Sobeys, wherever you go. But I know when I go to the US, for example, when I'm visiting Grand Forks or Fargo with my family, last year, I actually saw in the aisle there at Walmart, actually, that they had flax milk.
Oh.
So next time you go to your grocery store, just check, because there's a lot of almond milk and all these other non-alternative milks. And just a reminder for the audience is that when I'm chatting about flax milk or oat fiber milk, milk is in quotations. There's no dairy in any of these products. It's actually a liquid based that looks like milk because it's white. But yeah, next time you're at your grocery store, just check out to see if there's any flax milk. I haven't personally seen it in Winnipeg yet, but if you do find it, let Kathleen know, and then we'll go from there.
Yeah, thank you. Just a couple of difficult terms again to pronounce: docetaxel and cyclophosphamide.
Yeah. So docetaxel and cyclophosphamide are two chemotherapy medications that are often used in combination with women with breast cancer. They are not known to cause injury to the heart like doxorubicin. I know it's an awful thing, right? Doxorubicin and docetaxel sound so similar to each other, but docetaxel itself has no effects on the heart. So you'll notice that your cancer specialist or family doctor will not order a MUGA scan because there's no need to, because I have not seen any injury to the heart from those two drugs.
Okay, great. Yes, that's super. I just want to let you know that Ali's just sent me a note that says, everyone says Dr. Jassal is amazing and kind, and thank you for answering all their questions.
Thank you, folks. I appreciate that. Anytime.
That's awesome. Thank you so much for making time for us. This has just flown by. We hope that we were able to answer everyone's questions. I'm not sure if Ali kept up with all of that. That was great. She said they were flying in, so flying onto my desk. But we really appreciate you making time for us. This has been really interesting and obviously much needed information that people have been seeking and really curious about. So yeah, that's great. Thank you for all of you for tuning in today and for your questions. It's been wonderful.
Yeah, no, thank you very much for the kind invite and great questions from the crowd. You kept me going. And I think for myself and Kathleen, the hour just flew by. And happy to do this again, Kathleen. So, 2023, 2024, let's do this again. Maybe it'll be in hybrid mode. We'll see how it goes.
That's great. Thank you. Just to our audience, if you could take a minute to complete our survey, we really value your feedback. And just to let you know, we have another webinar coming up next month, and you will be receiving information about that shortly. So thank you again, Dr. Jassal, and thank you all. Take care for now.
Enjoy the weekend, everyone. Bye.
Likewise. Bye.